So good afternoon. Welcome, everybody. My name is Dr. Clifford Mitchell, and I am the Director of the Environmental Health Bureau at the Maryland Department of Health and Mental Hygiene here in Baltimore. I'd like to welcome everybody to this Public Health Grand Rounds, which is co-sponsored by the Department of Health and Mental Hygiene and the Johns Hopkins Mid-Atlantic Public Health Training Center. On behalf of both of us, I'd like to welcome you to this Grand Rounds. And the topic for today is lead poisoning, CDC's new target for prevention. Before we start, I'd like to give a couple of upcoming trainings for everyone to be aware of. I'd also like to mention to everybody that if you are online or want to be online, you can visit our website, and the website has all of the upcoming trainings. It also has a way for you to contact us during today's Grand Rounds so that you can ask questions online. We will moderate those, and after the formal presentations, we'll take your questions from the online audience as well as the audience here in Summer Hall here at the Johns Hopkins Bloomberg School of Public Health. Please also, if you are watching online, please sign in. This allows us to know both how many people we have and it gives us an idea of how to plan future events. So please sign in if you are watching online. We are very pleased today to have with us two experts in the field of lead poisoning prevention. And this is a topic that, as you know, has gained singular resonance over the last year or so because of changes at the federal level in terms of recommendations on the recognition and management of lead poisoning and lead exposure. Our first speaker today will be Dr. Ana Navas-Acien, who's an associate professor here at the Johns Hopkins Bloomberg School of Public Health. Dr. Navas-Acien got her PhD here in epidemiology in 2005. She is a physician and epidemiologist with a special interest in the health consequences of widespread environmental exposures, and she has done considerable work in the areas of chronic health effects of heavy metals, including arsenic, selenium, lead, cadmium, and other trace metals. Dr. Navas-Acien works closely with collaborators here at the Department of Environmental Health Sciences, and her research has helped clarify some of the issues in low-level exposures to populations, which is particularly relevant for today's discussion. Our other speaker today is Dr. Pat McLaine. Dr. McLaine, who is at the University of Maryland in the School of Nursing, has more than 30 years of experience in public health programming as a nurse and public health professional. She's worked at the local, state, and national level on numerous advisory boards and with departments of public health. And she works very closely as chair of the state's Lead Poisoning Prevention Commission with the Maryland Department of Environment and the Maryland Department of Health and Mental Hygiene on issues related to lead poisoning prevention. Her background is in nursing, as I said, from the Francis Payne Bolton School of Nursing at Case Western Reserve University. She also has an MPH from Johns Hopkins from the School of Hygiene and Public Health, and her doctorate in public health is from the Johns Hopkins Bloomberg School of Public Health. It's a pleasure for me to introduce both of these distinguished guests and to have them come up and address this issue of CDC's new target for prevention for lead poisoning prevention.
So thank you, Dr. Mitchell, for your introduction. And hello, everybody, and welcome, and thank you for being here, all of you who are on site and also all of you who are online. So today's, our goal was to talk about lead poisoning and how the new CDC target is going to change the way we do public health practice, and also how this might really impact lead exposure for children especially, but also for adults and for the population in general. So both Dr. McLaine and myself will be presenting this topic and will be discussing this topic. And so we wanted to frame the question first talking about exposure, what has happened in the US. This is very well known, and which are the current sources that we are concerned about. Also, kind of do a small overview about the health effects, especially at the low, moderate levels of exposure that we are currently exposed to, and include, as I said, both children and adults. And then also talk about the prevention strategies. So I'll be covering mostly those topics, but then Dr. McLaine will also be covering some of these issues, like to complement some of the things that I will be not talking so much in detail. And then the second piece of the talk, Dr. McLaine will focus on talking about the new target and which are the implications and which are kind of the challenges and also the next steps. But first of all, as Dr. Mitchell mentioned, I've been working on this topic with a number of collaborators here at Hopkins and also from outside Hopkins. So I wanted to acknowledge them, and because most of the research that I have been presenting and discussing, many of the ideas, we have this very active group on the impact of heavy metals at low, moderate levels of exposure, including lead, on chronic health effects. And so I wanted to acknowledge Dr. Wayar, Silvergold, Virginia Weaver, and also some of my students and postdocs, Esther Garcia, Andrea Apostolou, some of this research that they've done, I'll be showing it, and also Dr. Fadrowski, Schwartz, and Rothenberg. So we all know that lead, it's a very toxic metal. It's been used since very ancient times because of its physical and chemical properties that make it very useful for humans in many different ways. It was so that use by humans made it very ubiquitous in the environment, especially in the last century. And through mining, smelting, the production still used today in batteries, ammunition, metal products, medical research equipment, we still have lead in many of those products today, resulting in issues with recycling of these equipments and what happens with recycling and additional pollution of the environment. Also in ceramic glazes, still used today, and in paint, where it was banned several decades ago. In gasoline was the big issue with spreading really lead into the environment, and it was phased out in the 70s. And as a result, lead is in air, food, drinking water, rivers, lakes, and oceans, dust, and soil. Something that is interesting to know is that this change in lead in the environment, and many of you probably know this, we know it's been very dramatic historically. And if we look at the ice, snow strata, we can see that the levels dramatically change, especially in the 20th century. But actually starting with the Industrial Revolution, that resulted in this change in environmental exposures that spread all around the globe, including the Arctic ice. And in the 20th century, the main two sources of exposure were lead paint, so the white lead curve here in the figure. And you can see how in terms of tons of lead consumed, it was really dramatic, very high consumption during the beginning of the 20th century, and then dropping down as it was banned and phased out. And for tetraethyl lead used in gasoline, it peaked during the 70s, and then it was kind of also phased out and finally banned, and so it went down. So very, very different patterns of exposure. With respect to lead in gasoline, that resulted in really very high concentrations in the air. And here we only see the drop in air concentrations after the banning of lead in the use of lead in gasoline. And you can see how that really parallels the lead consumption in gasoline. And those big changes, and we can imagine that those also went up. We don't have the up in the curve because we didn't have such a good monitoring of lead in the air before. So monitoring lead in the air was a consequence of the awareness of what was happening. So we have a very good data to track it down, but not so well to track it up. But also we have good data from the biomonitoring perspective to track it down in the human populations. And we can see how in using the NHANES data, blood lead levels went dramatically down from the late 70s to the early 2000s. And this dramatic change resulted in changing completely the distribution of blood lead levels in the population. We went from a normal distribution, when lead was very common in the air, in the environment, to a very skewed distribution. So we were able to push completely the distribution to low levels with this very important public health intervention of banning lead in gasoline, mostly, and then banning the lead paint and the other initiatives. But the banning lead on gasoline is really the critical issue that changed the distribution. And I would say this is a beautiful example of a population-level prevention intervention, as compared to a high-risk prevention intervention. So in a high-risk prevention intervention, you would just focus on the kind of high-risk groups and try to protect those people. In a population-level type of intervention, you try to protect everybody and change that hazard among everybody. And that really makes the distribution to push towards the left. No? And so this was very successful, but now this result, and this is the second histogram is from NHANES 3, but it's very similar today, forward to the left, but still similar, no, and very skewed. So that result, in lots of groups in the population that remain at high risk. So when we think about the big public health success of banning lead in gasoline, we need to remember two things. First, that lead remains in the environment at very high concentrations compared to what humans were exposed before the Industrial Revolution. So even if the levels have decreased dramatically, doesn't mean that the problem is not there, because there might be health effects at these very low levels still. And second, that we still have a group of people with this very, very long tail that remains that are at very high risk. And those people are not homogeneously distributed in the population, but they are in certain groups, certain areas. So among those groups, those areas, we can also think about additional measures, even if it could be a high risk, but it would be like population-level interventions that could also help those populations that are in certain groups. So children are definitively one of those groups at high risk, and both because of heavier exposures, because of their behavior, and because of they drink and eat and breathe more per weight compared to adults. And also thinking not just in terms of exposure, but in terms of susceptibility, they might have special metabolic conditions that might make them, put them at higher risk. Such as, for instance, in terms of lead, because of the neurocognitive effects of lead, the fact that the blood-brain barrier is not yet fully developed early in life. So those are important aspects that make children be in a special group. The other one, if we think about the relative bioavailability of ingested lead from soil, certain types of lead, depending on the source of lead, the type of soil, for instance, lead paint has a relatively high bioavailability, so that's going to also contribute to these children being at increased risk of exposure. So in this figure, even if it's a little bit outdated, but it's a good representation to give us an idea that it's really when children move from their first year of age to their second year of age where there is a big change in the risk of lead exposure, resulting in some cases in very elevated lead levels, here using the cutoff of 10 and higher. No? It's categorized as 10, between 15 and 19, etc. in the figure. But you can see how there is a big change. And why is that? It's because the big change in behavior between a baby that doesn't move and a toddler that is immediately moving everywhere, no? And being exposed to lots of different risks. And there might be other reasons, but that's one of things that we can think very plausible. And this risk remains really high during the second, third year of life. Then it goes a little bit down, but it still remains quite high in subsequent years. And in this figure, again, this kind of just documents the change in average lead levels, these are medians, in recent enhanced data, so recent years in the US, but just comparing 1999-2000 to 2001-2002, we can see there was already a big drop. So each year we are doing better. So that's good. We still have a lot of things to do, but that's kind of good. This is population-wide, and we need, and Pat is going to really show us how what happens at the average level, in the average population overall in the US, doesn't necessarily translate to all the high-risk groups that I was mentioning earlier that we need to be paying attention to. And so when we talk about also lead and lead exposure, lead biomonitoring, we are always using, or we generally use, blood lead. And blood lead is the biomarker that has been used to for monitoring and surveillance of lead exposure. Why is this? First, it's a good, we can measure it relatively easy. Second, it's a good, the half-life of blood lead is quite adequate to monitor ongoing exposures. We can then see if interventions work or not. So it's because if it eliminates the exposure, then you would expect that in a month or so, this child or this person should have lower blood lead levels. But lead, it's not easily eliminated from the body. And that's also to always remember, no? Is that lead exposure is going to be stored generally in the bones that accumulate most of the body burden of lead. And in bones, the lead, its half-life is decades. However, it's not used for biomonitoring because it will be first of all, it's expensive. There are hazards from doing the K-X-ray fluorescence and other issues. But so generally, this bone lead is mostly used for research and not for biomonitoring. So which are the health effects that we are worried? So many, because lead is a pluritoxicant, so it affects many organs and systems in the human body. The best known health effects are the neurocognitive effects, and those have been shown both in children and adults. In adults, I am not going to be talking much about the neurocognitive effects. I'll just mention it briefly now. For instance, we know that there's effects on cognition as people age. However, there are not good studies actually done looking at the impact of lead in Alzheimer's or the epidemic of Alzheimer's nowadays, things like that. So that research would be really important to really understand what is the impact on not just cognitive losses in cognition, but really actual disease. And so that kind of areas of research that maybe are challenging to do, or it's hard to get money funding to do those type of studies, but I think would be really important. In addition to the neurocognitive, the nephrotoxic effects of lead have been known for a long time at high levels. But in recent years, we've known more and more about the effects at low levels, including very low levels as less than 5 micrograms per deciliter. We can see very clear dose-response relationships with worsening of kidney function. So this is actually quite compelling, and we've seen this both in adults and children. The immunotoxic effects of lead have been also described. It induces anemia. Those are generally at higher levels, but also it's less well studied or known at the lower levels. It can affect bone and teeth metabolism because it replaces calcium. It's classified as a probable carcinogen, although the carcinogenesis of lead is not as clear as for other metals, such as cadmium or arsenic. Actually, that fact made it possible for lead to be added to gasoline. When people said at the beginning in the early 20th century, got this idea of using lead, some people raised concern about adding a heavy metal to gasoline. And people are starting to look at cancer, and they actually saw that it was not easily carcinogenic compared to cadmium or compared to arsenic. And then they thought, okay, it's good, it's not toxic. And so that's an interesting thing kind of to know. But nowadays, it's classified as a probable carcinogen, but not as a definitive carcinogen. That is what these other metals are classified as. And then finally, the cardiovascular outcomes of lead are a group of outcomes that are very important because of the high burden of cardiovascular disease in the population and the potential of lead to really be contributing a portion of that cardiovascular disease risk. So I am going to be talking a little bit more about this in a few slides because that's the research that I am myself been involved, so I would like to describe it a little bit in more detail. So with respect to the neurocognitive effects, since these are so important for children, I wanted to bring kind of the study that summarized most of the evidence that was available at the time. This was published in 2005, and it pooled studies conducted in the US, in Europe, in Mexico, and in those studies kind of consistently they could see that there was a decrease in IQ with increase in blood lead levels. But what was interesting is that they tried to assess the shape of the dose response. And what they saw, so in this model you can see, if you use the straight line, you look at the straight line, it's a 5-knot spline model. That's a very flexible type of modeling. So it's trying to just look, what does the data say? What is the shape of the dose response? And if you then compare with a log linear model, where you are trying to force in the data the relationship to follow this log linear fit, you can see they look both very similar. So what does that type of model tell us? What this is telling us is that the impact in IQ is actually stronger at low levels of lead than at higher levels. So that means that a change in 1 unit of lead exposure, like for instance, from going from 1 to 2, is much worse in effect than from going from 20 to 21. So like if once you have 20, one change in 1 more unit is not as bad as from when you start at very low levels. So that's what this model shows. And you can see here the impact from going from 2.4 to 10 micrograms per deciliter, sorry, there is an error here, has an impact of 3.9 IQ decrements versus going from 20 to 30 only has a 1.1. So that's what the model says. And actually, this model works very well for IQ and also for blood pressure levels. So that's telling us that both for blood pressure and for IQ, this could be true, that the impact of lead at these low levels is even worse than at high levels. Doesn't mean that at high levels is not bad. At high levels is bad because you accumulate all the effect, no? It's just that it doesn't go much, much worse. So then what happens with adults, no? So in adults, we are very worried about the health effects of lead. Adults have generally always been not considered so important as compared to children in the lead world, I would say so, no? As a researcher that have done research in adults, I think that would be a fair thing to say. And it's important because their exposure accumulates, as we say, and because of many of these health outcomes that we are talking about, such as nephrotoxicity, cardiovascular toxicity, is really important for adult populations. So cardiovascular outcomes could be very important, and I wanted to talk a little bit more about this. And the first thing I wanted to kind of to show, just as a maybe anecdotal a little bit, is that if we look at the epidemic of cardiovascular disease, especially coronary heart disease in the United States, it really tracks very well the changes in blood lead levels in the US population due to the gasoline, with a very high increase in coronary heart disease from the early 20th century. We don't have the line going on, but coronary heart disease that is mostly due to atherosclerosis, was mostly inexistent at the beginning of the 20th century, very low rates. It went up dramatically until the late 60s, early 70s, exactly when gasoline was, and then it was, ban went down dramatically too. And actually, in the cardiovascular disease world, there are always like the traditional control of risk factor, traditional medical interventions do not really fully explain this big drop. So there is room for environmental exposures to really play a big role. But we don't have all the evidence to make that argument. We really need those strong studies. So let's see what we have, no? There is some suggestive evidence. Actually, the first evidence that we have available is really old. There is even a study that is much earlier than this one, but it was in French, so I thought that I will bring this English paper published in the British Medical Journal in 1886, where they describe arterial effects in autopsies of people who had died of lead gout. And so Saturnine gout, it's called, because Saturn was the god in Rome for the metals. No? And so it says that the reasons for this effect could be due to atherosclerosis, to hypertension, and to some of renal effects of lead. I thought this is amazing that already so early on, they really could have a hint of what was happening. So we did a systematic review a few years ago, and we tried to compile the evidence on lead and cardiovascular disease. And the conclusions of that review were that for blood pressure levels, for hypertension, we had good evidence of a causal association, based both on the epidemiological evidence and the experimental evidence. 2 minutes. Sorry, I am sorry that it's because I didn't know that I only had 2 more minutes, and because I thought it was until 1:30 and that we could have like 30 minutes each to present. But that's okay. I am going to kind of go a little bit faster. Sorry for this interruption. So in conclusion, we have good evidence for blood pressure levels, but some very suggestive evidence for coronary heart disease and for some other cardiac function abnormalities. So I am going to skip the cardiovascular evidence, but in general, as a conclusion, as I mentioned, it was very good for blood pressure and suggestive for the other outcomes. And this has important implications for preventions in adults that have so far not been generally considered in lead prevention programs. And one of the first implications is what's happening with the safety standard for workers. We are still at 40 micrograms per deciliter with absolutely no change since for many, many decades. So if we compare what has happened for lead safety standard for children versus adults, there is a big, doesn't make any sense. For children, we've been dropping it. For adults, it has remained very high. So in terms of lead poisoning prevention programs that mostly focus on children and also somewhat in pregnant women, so those are based on surveillance, secondary prevention measures, and Pat is also going to cover a little bit more about this, but basically doing case management of children with elevated blood lead levels at different cutoffs over time, and also trying to identify which are the most important sources of lead exposure for those children. And then in terms of primary prevention, that is going to be really important to really prevent exposure in the population at large, but also in those high-risk groups of the population that I was mentioning. There is a need of identifying the most common sources and to do some types of activities so that we can make sure that children are not exposed. Something that I noticed myself, because I do a lot of tobacco smoke research, is that secondhand smoke was generally not included in lead prevention programs. And so that's something that I was myself interested because preventing secondhand smoke is feasible. It's relatively easy to do, actually, as compared to preventing lead exposure from lead paint or other things that are so complicated. So that's something I wanted to really look into. So we did a project a few years ago with actually one MPH student and then also with some of my postdocs. She finished the work, and Pat was also involved. And so what we found is that both using cotinine as a marker of secondhand smoke exposure or counting the numbers of smokers who lived at home, children with increasing secondhand smoke exposure had higher blood lead levels. So you can see 48.7% higher blood lead levels with increasing no matter after adjustment for sociodemographic and even the year the home was built, supporting really secondhand smoke being an important source of exposure for lead. And this was consistent for most subgroups. The other thing that we did is to try to see if this could be related to inhalation or to exposure through dust, and maybe intake through dust. And so when we accounted for dust, there was no change in the association, suggesting that direct inhalation could be very important. This is not a surprise because lead is actually in the gas phase in secondhand smoke. And we can imagine that exposure to lead through inhalation can be important for children who live with smokers. And I took this picture from one of the major Spanish newspapers. It was published on the front page with an article related to something else. It was some parents protesting for something. And I couldn't just believe the picture, no? Because not only we have the mother here, but also there is somebody else behind who is also smoking. So this child is exposed to secondhand smoke, but also very possibly to lead. And this is kind of a source of exposure that we are not accounting, and that could also contribute to lower blood lead levels. So what I thought in terms of implication from public health from this research is that really there is more need sometimes for talking between programs and public health programs and prevention programs, because we can learn a lot from each other. And even sometimes maybe people cannot quit smoking, but maybe people can learn not to smoke within their houses, just to smoke outside, to smoke far away from their children. And that's going to benefit and reduce lead exposure. What could also help families to think about secondhand smoke, because sometimes people in certain groups of the population might not even be so aware of the health effects of secondhand tobacco smoke, or it might be hard for them to quit. And the fact, if they know that this could prevent lead, could be an additional motivation for them to not smoke in front of their children. So this was kind of all what I wanted to cover, and now I'm going to give the stage to Pat McLaine, Dr. McLaine, and she's going to be focusing on this new target and what the implications and what should we do.